Hello, I am Dr. Owen On, and welcome to the next installment of the Boring Lecture Series. Today Wes Hall examine a research paper published in the journal PLOS One on February 11, 2026, which addresses a topic of considerable technical specificity within the field of veterinary medicine. Namely the comparison of three distinct diagnostic methodologies employed for the assessment of respiratory dysfunction in calves that have undergone long-distance transport. The paper in question was authored by Van Dijk and colleagues, working at various institutions including Tegask Animal and Grassland Research and Innovation Centre in Moorpark, Fermoy, Ireland, and Wageningen University and Research in the Netherlands. The study participants consisted of 65 calves transported from Ireland to the Netherlands over the course of two separate transport cohorts in April and May of 2022. The primary objective of this investigation was to undertake a comparative analysis of three screening methodologies, which are thoracic ultrasonography, referred to throughout the study by the abbreviation TUS, clinical respiratory scoring, referred to by the abbreviation CRS, and various blood variables that serve as indicators of immune function and inflammatory status. The purpose of comparing these three methodologies was to assess the degree to which they agreed in identifying respiratory dysfunction in calves that had been subjected to long-distance transport. This is a matter of some practical importance because bovine respiratory disease represents a significant concern in the context of calf transport, and the ability to accurately identify calves with respiratory dysfunction prior to transport may reduce disease prevalence following transport, which would in turn improve calf welfare outcomes and reduce economic losses associated with treatment and mortality. Before proceeding to the specific details of the study methodology and findings, it is necessary to provide some background context regarding bovine respiratory disease and its relationship to animal transport. Bovine respiratory disease, which is sometimes abbreviated as BRD, is characterized by inflammation of the upper respiratory tract, the lower respiratory tract, or both respiratory tract regions. The disease may be caused by various viral pathogens or bacterial pathogens, or indeed by a combination of viral and bacterial pathogens acting in concert. The economic impact of bovine respiratory disease on dairy and veal production systems is considerable, with losses arising from multiple sources including the direct costs of treating affected animals, reduced growth rates in animals that have experienced respiratory disease, and mortality in severe cases. To elaborate further on the economic implications, it should be noted that treatment costs include not only the direct expense of antibiotics and other medications, but also the labor costs associated with identifying sick animals, administering treatments, and monitoring recovery. The reduced growth rates observed in animals that have experienced respiratory disease can persist throughout the production cycle, meaning that even animals that recover from acute disease may never achieve the same market weight or milk production as animals that remained healthy. This reduced productivity translates into reduced revenue per animal. Mortality, when it occurs, represents a complete loss of the investment in that animal, including all costs incurred from birth through the point of death, with no revenue to offset these costs. When these various cost components are aggregated across large numbers of animals in commercial production systems, the total economic impact becomes substantial. In the specific context of animal transport, respiratory disease is particularly problematic because the mixing of animals from different sources during transport results in increased exposure to pathogens, while the physiological stress associated with transport may compromise immune function and increase susceptibility to infection. The mixing of animals is an inevitable consequence of commercial livestock transport operations, where animals from multiple farms are typically consolidated at assembly centers before being loaded onto transport vehicles for more efficient movement. Each farm environment has its own particular complement of microbial organisms, and when calves from different farms are brought together, each animal is suddenly exposed to organisms to which it has not previously been exposed and against which it may not have developed immunity. This phenomenon is well documented in the scientific literature and is sometimes referred to as the disease challenge of commingling. The practice of transporting unweaned calves over long distances is common in certain production systems, particularly in European veal production, where calves are frequently transported from dairy farms in one country to specialized veal rearing facilities in another country. During such transport, calves are exposed to numerous potential stressors, including prolonged periods without feeding, changes in environmental conditions, novel social environments due to mixing with unfamiliar animals, and the physical demands of maintaining balance during vehicle movement. These stressors, when combined with increased pathogen exposure from commingling, create conditions that are highly conducive to the development of what is sometimes termed shipping fever, which is essentially transport-associated respiratory disease. To provide more detailed elaboration on each of these stressor categories, we shall begin with the matter of feeding disruption. Under normal circumstances on the farm of origin, young calves typically receive milk or milk replacer at regular intervals, commonly twice daily, though some management systems may provide more frequent feeding opportunities. During transport, these regular feeding schedules are necessarily disrupted, and there may be extended periods during which calves do not receive any nutrition. The duration of these fasting periods depends on the length of the transport journey and the scheduling of rest stops, but can extend to many hours or in some cases more than a day. Even when feeding opportunities are provided during rest stops, as required by animal transport regulations in many jurisdictions, calves may not consume adequate amounts due to unfamiliarity with the feeding equipment, competition with other calves, or reduced appetite due to stress. This nutritional deprivation has multiple physiological consequences. First, it results in depletion of energy reserves, which are already limited in young calves. Second, the lack of nutrient intake means reduced availability of substrates needed for immune function, as the immune system requires adequate nutrition to mount effective responses to pathogens. Third, fasting has been shown to have direct effects on gut barrier function, potentially increasing intestinal permeability and allowing bacterial translocation, which can contribute to systemic inflammation. Regarding environmental changes, calves during transport are exposed to fluctuations in temperature, humidity, air quality, and noise levels that differ substantially from their farm environment. Temperature regulation is particularly challenging for young calves, whose thermoregulatory capacity is not fully developed. During transport, calves may experience both heat stress if ambient temperatures are high and ventilation is inadequate, or cold stress if temperatures are low, particularly during nighttime or when vehicles are moving at highway speeds, creating wind chill effects. Humidity levels can also fluctuate considerably, with high humidity conditions developing in poorly ventilated transport vehicles due to moisture from respiration and urination, while very low humidity can occur in heated vehicles. Air quality within transport vehicles can be compromised by accumulation of ammonia from urine, particulate matter from fecal material and bedding, and respiratory pathogens aerosolized from infected animals. Noise levels during transport are substantially elevated compared to typical farm environments, due to engine noise, road noise, and vocalizations from stressed animals. Each of these environmental factors has been shown in research studies to elicit stress responses in cattle as measured by various physiological indicators. The social stress associated with mixing unfamiliar animals warrants particular attention. Cattle are social animals that under natural circumstances live in stable social groups with established hierarchies and individual recognition among group members. When calves from different farms are mixed during transport, the entire social structure must be renegotiated, which involves agonistic interactions including threatening behaviors, displacements, and in some cases physical contact such as pushing or headbutting. These social interactions require energy expenditure and create psychological stress. Additionally, the presence of unfamiliar animals is itself a source of uncertainty and potential threat from the perspective of the individual calf. The stress response to social disruption involves activation of the hypothalamic pituitary adrenal axis, resulting in elevated cortisol secretion, which has well-documented immunosuppressive effects. Specifically, elevated cortisol levels can reduce the proliferation and function of lymphocytes, decrease antibody production, and impair the activity of various other immune cells, thereby increasing susceptibility to infection. The physical demands of maintaining balance during vehicle movement represent another important stressor. Transport vehicles undergo constant accelerations, decelerations, and changes in direction as they navigate traffic, make turns, ascend or descend grades, and respond to road surface irregularities. Calves must continuously adjust their posture and muscle tension to maintain balance in response to these perturbations. This requires sustained muscle activity that can lead to fatigue, particularly in young animals with limited muscular development. The energy expenditure associated with this balance maintenance adds to the overall energy deficit created by fasting. Additionally, the inability to rest in a normal lying posture during much of the transport period, due to concerns about being stepped on by other calves or inability to rise from lying position due to space constraints and vehicle movement, results in sleep deprivation and associated physiological consequences. Research using accelerometers and behavioral observation has documented that calves spend substantially less time in recumbent rest during transport compared to normal farm conditions, and this sleep deprivation persists even during rest stops when time constraints and unfamiliar environments may prevent normal sleep patterns. Given the welfare and economic concerns associated with respiratory disease in transported calves, there is a clear need for reliable methods to identify animals that are unfit for transport due to existing respiratory pathology, as well as methods to monitor respiratory health status following transport in order to facilitate timely therapeutic intervention. The study under consideration here examines 3 such methods, and we shall now proceed to examine each of these methods in turn before discussing the comparative findings. The first method to be considered is clinical respiratory scoring, abbreviated as CRS. This method involves visual assessment of various clinical signs that may indicate respiratory disease. The specific system employed in the study under discussion was based on the Wisconsin Calf Health Scoring Chart, which has been described in the veterinary literature, with certain adaptations made for practical application in the context of transport research. The clinical variables assessed in the scoring system include eye discharge, nasal discharge, ear position, cough frequency, and rectal temperature. Each of these variables is assigned a numerical score based on the severity of abnormality observed, and the individual scores are then summed to produce an overall clinical respiratory score. In greater detail, the scoring system operates as follows. For eye discharge, a score of 0 is assigned when there is no discharge present. A score of 1 is assigned when a small amount of ocular discharge is present. A score of 2 is assigned when a moderate amount of bilateral ocular discharge is present, and a score of 3 is assigned when heavy ocular discharge is present bilaterally. The assessment of eye discharge requires the observer to examine both eyes of the calf and make a determination about the quantity and consistency of any discharge material present. Normal eyes should appear clear and bright with no accumulation of discharge material at the medial canthus, which is the inner corner of the eye where the upper and lower eyelids meet. Small amounts of clear discharge may be present normally and should not be scored as abnormal. The scoring system specifically looks for increased amounts of discharge and for bilateral presentation, meaning discharge present in both eyes rather than just one eye. The discharge in respiratory disease may be serous in nature, meaning clear and watery, or may be mucoid, meaning thicker and more viscous, or mucopurulent, meaning containing both mucus and purulent material, which gives it a cloudy or yellowish appearance. The presence of mucopurulent discharge generally indicates more severe or advanced infection. The observer must make a subjective judgment about what constitutes a small amount versus a moderate amount versus a heavy amount of discharge. This subjectivity represents one of the limitations of clinical scoring systems. Different observers may have different thresholds for what they consider to be moderate versus heavy discharge, and even the same observer may vary in their scoring over time or between different calves depending on various contextual factors. For nasal discharge, a score of 0 is assigned when there is no nasal discharge. A score of 1 is assigned when small amounts of unilateral nasal discharge is present. A score of 2 is assigned when bilateral cloudy or excessive nasal discharge is present. And a score of 3 is assigned when copious bilateral mucopurulent nasal discharge is present. The assessment of nasal discharge requires examination of both nostrils to determine whether discharge is present and, if so, whether it is unilateral or bilateral, and to characterize the quantity and quality of the discharge. Normal calves may have small amounts of clear serous discharge from the nostrils, which should not be scored as abnormal. The progression from score 1 through score 3 reflects increasing severity in terms of both the extent of involvement, moving from unilateral to bilateral presentation, and the character of the discharge, moving from small amounts to excessive amounts and from clear to cloudy to mucopurulent. Mucopurulent nasal discharge is particularly significant as it indicates bacterial involvement in the respiratory infection. The term copious, used in the description of score 3, indicates a very large amount of discharge that may be dripping from the nostrils or crusted around the nares due to dried discharge material. Again, the subjective nature of these assessments creates potential for inter-observer variability and intra-observer variability over time. For ear position, which serves as an indicator of overall malaise, a score of 0 is assigned when the ears are in a normal position. A score of 1 is assigned when the ears are slightly drooped or the head is carried slightly lower than normal, and a score of 2 is assigned when the ears are significantly drooped or the head is held significantly low. The assessment of ear position and head carriage requires the observer to compare the observed calf's posture to their mental template of what constitutes normal posture for a calf of that age and size. Normal ear position in an alert calf involves the ears being held erect and oriented forward or to the sides, with active movement as the calf monitors its environment. When a calf is experiencing malaise, which is a general feeling of discomfort or illness, the ears tend to droop, meaning they are held more horizontally or pointing downward rather than erect. Similarly, the head may be carried lower than normal, with the muzzle closer to ground level rather than held up. These postural changes reflect reduced alertness and reduced muscle tone associated with illness. The distinction between slightly drooped ears and significantly drooped ears, and between head carried slightly lower than normal and head held significantly low, again involves subjective judgment on the part of the observer. What one observer considers slightly drooped might be considered significantly drooped by another observer, or might be considered normal by yet another observer. Additionally, ear position and head carriage can be affected by factors other than respiratory disease, including general fatigue, hunger, or other sources of stress, which means that abnormal scores for this parameter are not specific to respiratory disease. Regarding cough, a score of 0 is assigned when there is no coughing induced or spontaneous. A score of 1 is assigned when a single spontaneous or induced cough occurs, and a score of 2 is assigned when repeated spontaneous or induced coughing occurs. The assessment of cough involves both observation of spontaneous coughing that occurs without any intervention by the observer, and also induced coughing that occurs in response to tracheal palpation, which involves the observer applying gentle pressure to the trachea or windpipe in the neck region to stimulate the cough reflex. A normal calf should not spontaneously cough frequently, though occasional isolated coughs may occur normally, for example in response to dust or other airway irritants. The cough reflex is a protective mechanism designed to clear the airways of irritants, excess mucus, or foreign material. When respiratory disease is present, inflammation and mucus accumulation in the airways leads to increased cough reflex sensitivity, resulting in more frequent spontaneous coughing. Induced coughing in response to tracheal palpation is also more likely when airways are inflamed and sensitized. The distinction between a single cough and repeated coughing involves determining whether the calf coughs just once in response to the stimulus or whether it coughs multiple times in succession. The time period over which spontaneous coughs are observed must also be considered, as a calf might cough once during a brief observation period but might have coughed repeatedly if observed for a longer duration. This temporal aspect of the observation creates another source of potential variability in scoring. For rectal temperature, a score of 0 is assigned when the temperature is between 38.0 and 38.9 degrees Celsius. A score of 1 is assigned when the temperature is between 39.0 and 39.5 degrees Celsius. A score of 2 is assigned when the temperature is between 39.6 and 40.0 degrees Celsius. And a score of 3 is assigned when the temperature exceeds 40.0 degrees Celsius. The measurement of rectal temperature requires insertion of a thermometer into the rectum of the calf to a sufficient depth to ensure accurate measurement of core body temperature, typically approximately 5 to 8 centimeters in a young calf. Digital thermometers are commonly used for this purpose as they provide rapid results, typically within 30 to 60 seconds, and clearly display the measured temperature on a digital readout, eliminating the need to read a mercury column as with traditional glass thermometers. The normal rectal temperature range for a calf is generally considered to be approximately 38.0 to 39.0 degrees Celsius, though there can be some individual variation and some variation related to environmental conditions, time of day, and recent activity level. Elevated body temperature, termed fever or pyrexia in medical terminology, is a common response to infection, mediated by cytokines released as part of the immune response that act on the hypothalamic temperature regulation center to increase the temperature set point. Fever is thought to enhance immune function and inhibit pathogen replication, representing an adaptive response to infection. However, very high fevers can also have detrimental effects, and a temperature exceeding 40.0 degrees Celsius would be considered a significant fever warranting attention. The precise threshold values used in the scoring system, with breakpoints at 39.0, 39.6, and 40.0 degrees Celsius, are somewhat arbitrary but reflect attempts to categorize temperature elevations into clinically meaningful severity levels. It should be noted that temperature measurement is more objective than the assessment of discharge, ear position, or cough, as it yields a numerical value that does not depend on observer interpretation, though there can still be some measurement error related to thermometer accuracy, depth of insertion, and duration of measurement. The total clinical respiratory score is calculated by summing the individual scores for each of these 5 variables, producing a value that theoretically could range from 0, indicating complete absence of any clinical signs of respiratory disease, to a maximum possible score of 13, indicating the most severe presentation of clinical signs across all measured variables. For the purposes of the current study, these total scores were then grouped into 4 categories to facilitate comparison with the thoracic ultrasound scoring system, which also employs 4 categories. Specifically, total scores of 0 or 1 were classified as CRS category 0, representing healthy animals. Total scores of 2 or 3 were classified as CRS category 1, representing mild respiratory disease signs. Total scores of 4 or 5 were classified as CRS category 2, representing moderate respiratory disease signs, and total scores of 6 or greater were classified as CRS category 3, representing severe respiratory disease signs. It should be noted that clinical respiratory scoring, while widely employed in practice due to its relative simplicity and low cost, has certain well-documented limitations. Specifically, previous studies have reported that the sensitivity of clinical respiratory scoring for detecting respiratory disease is rather modest, with values ranging from approximately 0.27 to 0.64 in different studies, although the specificity tends to be somewhat higher, ranging from approximately 0.74 to 0.94. The sensitivity value indicates the proportion of animals with respiratory disease that are correctly identified by the scoring system, while the specificity value indicates the proportion of healthy animals that are correctly identified as healthy. A sensitivity of 0.27 would mean that only about 1/4 of animals with respiratory disease are identified by the scoring system, which clearly represents a substantial limitation if the goal is to comprehensively identify all animals with respiratory pathology. The second diagnostic method employed in the study is thoracic ultrasonography, which is abbreviated as TUS. This method involves the use of ultrasound imaging to visualize the lung parenchyma and identify abnormalities such as consolidation, which indicates areas where the normally air-filled lung tissue has been replaced by fluid or inflammatory material. The ultrasound examination is performed by placing an ultrasound probe against the thoracic wall in the intercostal spaces, which are the spaces between the ribs, and systematically scanning the entire lung field on both the left and right sides of the chest. To understand how ultrasound imaging allows visualization of lung tissue, it is necessary to briefly review some basic principles of ultrasound physics. Ultrasound imaging works by transmitting high-frequency sound waves into the body and detecting the echoes that are reflected back from tissue interfaces where there is a change in acoustic impedance. Acoustic impedance is a property that depends on the density and elasticity of the tissue. When an ultrasound wave encounters an interface between two tissues with different acoustic impedances, part of the wave is reflected back toward the probe while the remainder continues deeper into the tissue. The ultrasound machine measures the time delay between transmission of the ultrasound pulse and reception of the echo, which allows calculation of the depth at which the reflecting interface is located, and also measures the intensity of the returning echo, which provides information about the acoustic properties of the tissue. By transmitting many ultrasound pulses in rapid succession and detecting the pattern of returning echoes, the ultrasound machine can construct an image showing the spatial distribution of tissue interfaces. In the specific case of lung imaging, normal air-filled lung tissue creates a very strong reflection of ultrasound waves at the interface between the chest wall and the lung surface, because there is a very large change in acoustic impedance between the solid tissues of the chest wall and the air-filled lung. This strong reflection means that very little ultrasound energy penetrates into the air-filled lung, so the deeper lung tissue cannot be visualized. However, when lung tissue becomes consolidated due to infection or inflammation, the air in the alveoli is replaced by fluid and inflammatory cells, which have acoustic properties more similar to solid tissue. This consolidation reduces the acoustic impedance mismatch at the lung surface and allows ultrasound waves to penetrate into the lung tissue, making it possible to visualize the consolidated regions. Thus, consolidation appears on ultrasound as hypoechoic or anechoic regions, meaning regions that appear darker on the ultrasound image due to reduced echo intensity, in contrast to the bright hyperechoic line that represents the pleural surface in normal air-filled lung. The specific protocol employed in the current study was based on a system described by Olivet and Buczynski, with certain minor adaptations. Prior to scanning, the hair covering the thoracic region of the calf is saturated with 70% isopropyl alcohol solution in order to eliminate air between the probe and the skin surface, as air would interfere with the transmission of ultrasound waves. The presence of air between the ultrasound probe and the skin would create a strong reflection at the skin surface, preventing the ultrasound waves from entering the body. The alcohol serves to flatten the hair against the skin and to displace air from the spaces between hairs, creating acoustic coupling between the probe and the skin. Some ultrasound examination protocols use specialized ultrasound gel for this purpose, but alcohol is equally effective and has the advantage of being less expensive and requiring less cleanup. The complete saturation of the hair with alcohol throughout the entire thoracic examination area is important to ensure consistent acoustic coupling across all scan locations. The ultrasound equipment used was an EasyScan veterinary ultrasound scanner manufactured by IMV Imaging, located in Gormanston, Ireland. This device was set to a frequency range of 4.5 to 8.5 MHz and a depth setting of 11 centimeters. The selection of frequency represents a compromise between competing considerations. Higher ultrasound frequencies provide better spatial resolution, meaning better ability to distinguish small structures and detect fine detail, but they penetrate less deeply into tissue because they are more readily absorbed. Lower frequencies provide greater penetration depth, but with reduced spatial resolution. For thoracic imaging in calves, where it is necessary to visualize lung tissue several centimeters deep to the body surface, a relatively lower frequency within the typical diagnostic ultrasound range is appropriate. The 4.5 to 8.5 MHz range used in this study represents a reasonable balance for imaging young calves. Within this frequency range, the operator can select different specific frequencies depending on the size of the calf being examined and the depth of tissue that needs to be visualized, using lower frequencies for larger calves or when trying to visualize deeper structures. The depth setting of 11 centimeters determines how far into the tissue the ultrasound machine will image. This setting must be sufficient to include all lung tissue within the image, but setting the depth too large results in a smaller and less detailed image on the display screen because the available display area must be divided among more tissue depth. The 11 centimeter depth used in this study was appropriate for young calves of the size enrolled. The scanning procedure involves systematic examination of each intercostal space from the 12th intercostal space, which is the most caudal or posterior position, moving cranially or anteriorly to the 3rd intercostal space on the left side and to the 1st intercostal space on the right side. The ribs of cattle are numbered from cranial to caudal, with the first rib being the most cranial rib that articulates with the first thoracic vertebra, and subsequent ribs numbered sequentially moving caudally along the thorax. The intercostal space is the gap between adjacent ribs and is numbered according to the cranial rib, so the space between the first and second ribs is the first intercostal space, the space between the second and third ribs is the second intercostal space, and so forth. Cattle have 13 pairs of ribs, so there are 12 intercostal spaces on each side. However, the most cranial intercostal spaces on the left side cannot be scanned because they are obscured by the heart, which is positioned more to the left of midline in cattle. On the right side, the cranial intercostal spaces can be accessed but require lifting the right front leg to expose them, as they would otherwise be covered by the leg. At each intercostal space, the probe is initially placed dorsally near the spine and then moved ventrally or downward toward the belly, until the ultrasound image shows the end of the lung tissue within that particular intercostal space. The lung extends from the dorsal thorax ventrally toward the sternum, but does not extend all the way to the ventral midline because the ventral thorax is occupied by the heart and other mediastinal structures. As the probe is moved ventrally within an intercostal space, the ultrasound image will show lung tissue at the shallower depths until a point is reached where the lung ends and other structures such as the liver or heart come into view deeper in the image, or where the image shows absence of lung tissue. This process of scanning from dorsal to ventral allows the examiner to determine the full dorsoventral extent of the lung in that intercostal space and to identify any consolidation present anywhere within that range. This process is then repeated for each successive intercostal space moving in the cranial direction. The systematic nature of this scanning protocol is important to ensure complete examination of all lung tissue and to avoid missing regions of consolidation that might be present in areas that were not scanned. To access the first and second intercostal spaces on the right side, which would otherwise be obstructed by the right front leg, the leg is lifted by an assistant to allow probe placement in these locations. The lifting of the leg pulls the triceps muscle and other muscles associated with the forelimb forward and away from the cranial thorax, exposing the underlying intercostal spaces. This manipulation requires cooperation from the calf and assistance from a second person, adding to the complexity and time requirements of the examination. Some calves may resist having their leg lifted, particularly if they are already stressed from transport and handling, which can complicate the examination. The importance of examining these cranial right intercostal spaces stems from anatomical considerations related to the bronchial tree structure and the pattern of pathogen deposition in the lungs, which often results in preferential involvement of the cranial right lung in respiratory infections, a pattern that was indeed observed in the current study, as we shall discuss later. The ultrasound images obtained are then evaluated to assign a score based on the extent and nature of any abnormalities observed. The scoring system employed recognizes different levels of consolidation severity based on the depth of abnormal lung tissue observed in each of the 4 lung lobes, which are designated as right cranial, right caudal, left cranial, and left caudal. A score of 0 is assigned when no consolidation is visible, indicating healthy lung tissue. A score of 1 is assigned when consolidation is observed extending less than 1 centimeter from the pleural surface, which is the outer surface of the lung. A score of 2 is assigned when consolidation extends from 1 to 3 centimeters from the pleural surface. A score of 3 is assigned when consolidation extends more than 3 centimeters from the pleural surface in at least 1 lung lobe. A score of 4 is assigned when consolidation is present to a depth greater than 3 centimeters in 2 or more lung lobes. Finally, a score of 5 is assigned when consolidation with this extent is accompanied by pleural irregularities, which are abnormalities of the pleural surface itself. For the purposes of statistical analysis in the current study, the initial 6-point scoring scale was reduced to a 4-point scale because scores of 4 and 5 were observed very infrequently, occurring in only 4 cases out of 325 total observations. These rare high scores were reclassified as score 3 for analysis purposes. Thus, the final TUS classification system used in the analysis consisted of 4 categories, with TUS 0 considered healthy, TUS 1 considered mild respiratory disease signs, TUS 2 considered moderate respiratory disease signs, and TUS 3 or higher considered severe respiratory disease signs. The thoracic ultrasonography method has certain advantages compared to clinical respiratory scoring. Most notably, ultrasound examination allows direct visualization of lung pathology, including subclinical disease that may not yet be producing observable clinical signs. Previous validation studies comparing ultrasound findings to post-mortem examination results, which represent the gold standard for confirming respiratory disease, have reported that ultrasound has sensitivity values exceeding 0.85, in some cases reaching as high as 0.94, while specificity values range from 0.98 to 1.0. These performance characteristics are substantially superior to those reported for clinical respiratory scoring, suggesting that ultrasound may be a more reliable diagnostic tool. However, ultrasound examination requires specialized equipment, operator training, and considerably more time per animal compared to clinical scoring, which creates practical limitations for routine application in field settings. The third category of diagnostic information examined in this study consists of various blood variables that may serve as indicators of immune function and inflammatory status. Blood samples were collected from the jugular vein using a 20-gauge needle, with a total volume of 26 milliliters collected from each animal at each sampling time point. This volume represents approximately 0.63% of total blood volume for a 55 kilogram calf and 0.81% of total blood volume for a 43 kilogram calf, which was the lightest animal in the study. These percentages are well below the 1% safety threshold for blood sampling within a 24-hour period that has been established in veterinary practice guidelines to prevent adverse effects from blood loss. The collected blood was distributed among 4 different types of collection tubes containing different anticoagulants or other additives appropriate for different types of analysis. Specifically, 6 milliliters was collected into a tube containing AUDITORY, which is ethylene-dimene tetracetic acid, an anticoagulant that prevents blood clotting by binding calcium ions. Another 6 milliliters was collected into a tube containing heparin, which is an anticoagulant that works through a different mechanism. A third 6 milliliters was collected into a tube containing a glycolytic inhibitor, which prevents the breakdown of glucose in the blood sample. Finally, 8.5 milliliters was collected into a serum separator tube, abbreviated as SST, which allows the blood to clot and then separates the serum from the clotted cellular components. The AUDITORY tubes were refrigerated and used for hematology analysis, which involves counting and characterizing the cellular components of blood. The specific hematological variables measured included hemoglobin concentration, which indicates the oxygen-carrying capacity of the blood, red blood cell count, which is abbreviated as RBC, white blood cell count, which is abbreviated as WBC, and differential white blood cell counts, meaning the counts of specific types of white blood cells including neutrophils, lymphocytes, monocytes, basophils, and eosinophils. Each of these cell types plays different roles in immune function. Neutrophils are typically the first responders to bacterial infection. Lymphocytes are involved in both innate and adaptive immune responses. Monocytes can differentiate into macrophages that phagocytose pathogens and debris. Basophils and eosinophils are involved in allergic and parasitic responses, although their roles in respiratory disease are less prominent. An important methodological detail is that hematology samples collected in Ireland, which would be the pre-transport samples and assembly center samples, were analyzed using an ADVIA 2120 system at Tegas Grange Laboratory in Dunsany, Ireland, while all other samples, which would be those collected in the Netherlands after arrival at the veal farm, were analyzed using a different instrument. Specifically the XT1800i manufactured by Sysmex Europe at the Remondia Laboratory in Elspet, the Netherlands. This difference in analytical methods was necessitated by practical constraints, specifically the need to minimize the time between sample collection and laboratory analysis, as some blood parameters can change if samples are not analyzed promptly. All samples were analyzed within 48 hours of collection. To ensure comparability of results despite the use of different analytical systems, quality control samples were included in each analytical run, and the coefficients of variation for these quality control samples were calculated to assess the precision of each analytical system. For the Tegas Grange Laboratory, quality control samples at low, normal, and high concentration levels were used, while the Remondia Laboratory used only normal level quality control samples. The coefficients of variation, which express the standard deviation as a percentage of the mean and thus provide a measure of analytical precision, were reasonably low for both laboratories, indicating acceptable analytical performance. For hemoglobin measurement, the coefficient of variation was 1.31% for low-level controls, 0.89% for normal-level controls, and 1.73% for high-level controls at Tegas Grange, while at Remondia it was 0.78% for normal-level controls. For neutrophil count, the coefficient of variation was 4.75% for low-level controls, 2.33% for normal-level controls, and 3.21% for high-level controls at Tegas Grange, while at Remondia it was 3.2% for normal-level controls. One additional technical issue that required attention was the fact that hemoglobin concentration was reported in different units by the two laboratories, specifically in grams per deciliter in Ireland and in millimoles per litre in the Netherlands. To make these values comparable, the Irish measurements in grams per deciliter were converted to millimoles per litre by multiplying by a conversion factor of 0.6206, as specified in published conversion tables. Beyond the hematological analyses, additional blood variables were measured using the serum samples obtained from the serum separator tubes. These tubes, along with the heparin and glycolytic inhibitor tubes, were centrifuged to separate the cellular components from the liquid component, specifically at 3,000 revolutions per minute for either 5 minutes for the heparin and glycolytic inhibitor tubes or 10 minutes for the serum separator tubes. The serum was then removed from the tubes, transferred into storage tubes, and frozen at -20 degrees Celsius for preservation until analysis could be performed. All serum samples were eventually sent to the Tegas-Grange laboratory for analysis of specific proteins using enzyme-linked immunosorbent assay techniques, abbreviated as ELISA. The proteins measured included serum amyloid A, abbreviated as SAA, which is an acute phase protein that increases rapidly in response to inflammation or infection, immunoglobulin A or IgA, immunoglobulin G or IgG, and immunoglobulin M or IgM. The immunoglobulins are antibody proteins that play central roles in adaptive immune responses. IgG is the most abundant immunoglobulin in serum and provides long-lasting immunity. IgM is typically the first antibody produced in response to a new infection. IgA is important for mucosal immunity, including in the respiratory tract. Additionally, a total immunoglobulin value was calculated by summing the concentrations of IgA, IgG, and IgM. The rationale for measuring these specific blood variables relates to known patterns of immune response to respiratory infection. Previous studies in calves with respiratory disease have documented various hematological and immunological changes, including neutrophilia, which is an elevated neutrophil count, monocytosis, which is an elevated monocyte count, lymphopenia, which is a decreased lymphocyte count, and increased concentrations of acute phase proteins such as serum amyloid A. The neutrophil to lymphocyte ratio, which is calculated by dividing the neutrophil count by the lymphocyte count, has also been used as an indicator of stress and inflammation, with higher ratios generally indicating greater physiological stress. Having described the three diagnostic methodologies employed in the study, we shall now turn to the experimental design and sampling schedule. The study utilized calves from two consecutive commercial transport cohorts, designated as Cohort 1 and Cohort 2, which were transported in April and May of 2022 respectively. The calves originated from two types of sources, either dairy farms in the Munster region of Ireland or commercial livestock marts, which are auction facilities where calves are bought and sold. For the dairy farm calves, 8 different farms were selected by a collaborating exporter based on the criterion that each farm had at least 2 calves available for transport on the designated departure date. All calves over 14 days of age that were presented for export from these farms were enrolled in the study. For the livestock mart calves, 20 calves per cohort were purchased at commercial marts in Munster and enrolled in the study. Cohort 1 consisted of 37 calves, all of which were male, including 5 Holstein Friesian calves, abbreviated as HF, and 32 calves that were crosses between beef breeds and Holstein Friesian, abbreviated as Beef XHF. These calves had an average age of 29.6 days, with a range from 16 to 42 days, and an average weight of 55.1 kilograms, with a range from 44 to 67 kilograms, as measured at the assembly center. Cohort 2 consisted of 29 calves, including 20 males and 9 females. Among the males, 10 were Holstein Friesian and 10 were beef crosses, while all 9 females were beef crosses. This cohort had an average age of 28.6 days, ranging from 17 to 36 days, and an average weight of 57.3 kilograms, ranging from 43 to 72 kilograms, again as measured at the assembly center. The transport process followed a complex multi-stage route from Ireland to the Netherlands, which we shall now describe in detail. Calves originating from dairy farms were assessed at their farm of origin 1 day prior to transport to the assembly center, while calves that were purchased at livestock marts were assessed at the mart on the day of transport to the assembly center. From these origin points, calves were transported to a commercial export assembly center located in the Leinster region of Ireland, arriving at approximately midnight. Upon arrival at the assembly center, calves were unloaded into pens bedded with straw and allowed to rest overnight. The following morning, calves were fed 2 liters of milk replacer containing 21% protein and 17% fat, and then in the afternoon they were loaded onto a commercial 3-tier livestock lorry designed for transporting animals. The lorry then traveled to either Dublin Port for Cohort 1 or Rosslare Port for Cohort 2, where it boarded a ferry to Cherbourg, France. After arrival in France, the lorry drove to a control post in the Normandy region of France, which is a designated stopping point required by European Union regulations for long-distance animal transport, where calves must be unloaded for a rest period. At this control post, calves were unloaded and fed 3 liters of milk replacer containing 22% protein and 19% fat. After resting at this lairge facility for 13 hours, the calves were reloaded onto the lorry and transported to the final destination, which was a commercial veal farm in the Gelderland province of the Netherlands. Upon arrival at the veal farm, calves were unloaded and placed individually into pens measuring approximately 1 meter by 1.6 meters with wooden slatted flooring. The pens were separated by stainless steel fencing that allowed calves to see and touch neighboring calves but prevented them from moving into adjacent pens. This housing arrangement complied with European legislation regarding housing of veal calves. Calves remained in individual housing for 3 weeks following arrival. The feeding protocol at the veal farm followed standard industry practices. Immediately after arrival, calves received an electrolyte solution mixed in 2 liters of water for their first feeding. Subsequent feedings consisted of milk replacer containing 21% protein and 18.2% fat, provided twice daily in buckets. The initial volume was 1.5 liters twice daily, which was gradually increased to 2.7 liters twice daily by 3 weeks post-arrival. All calves received antibiotic treatment shortly after arrival, specifically an intramuscular injection of tilmacocin at a dose of 1 cubic centimeter. Additionally, calves received 2 further courses of metaphylactic batch antibiotic treatment in weeks 1 and 2 following arrival, specifically doxycycline administered in the milk at a dose of 0.03 grams per feeding, twice daily, for 3 days in week 1 and 5 days in week 2. This prophylactic antibiotic treatment is standard practice in commercial veal production systems to prevent disease outbreaks in recently transported calves that have been commingled and are at high risk for respiratory disease. The sampling schedule for the various diagnostic assessments was as follows. Time point 1, designated as T1, occurred pre-transport at either the dairy farm of origin or the livestock mart. At this time point, calves were assessed using both thoracic ultrasonography and clinical respiratory scoring, and blood samples were collected. Time point 2, designated as T2, occurred on arrival at the veal farm in the Netherlands, either 1 or 2 days post-arrival. At this time point, calves again underwent thoracic ultrasonography and clinical respiratory scoring, and blood samples were collected. Time point 3, designated as T3, occurred either 3 or 7 days after arrival, depending on the cohort. At this time point, thoracic ultrasonography and clinical respiratory scoring were performed, but no blood samples were collected due to logistical constraints. Time point 4, designated as T4, occurred either 9 or 10 days after arrival. At this time point, all 3 types of assessment were performed, including thoracic ultrasonography, clinical respiratory scoring, and blood sampling. Finally, time point 5, designated as T5, occurred 18 days after arrival for the ultrasound and clinical scoring assessments, or 21 days after arrival for blood sampling. The slight differences in the exact timing of assessments between cohorts and between different types of assessments reflect the practical constraints of conducting research in a commercial production setting. 1 calf from the original 66 enrolled was excluded from analysis due to a missing thoracic ultrasound observation, leaving a final sample size of 65 calves for analysis. In total, 325 thoracic ultrasound scores were recorded across the 5 time points for these 65 calves. Additionally, 322 clinical respiratory scores were recorded, the slightly lower number reflecting some missing observations primarily due to the fact that rectal temperature measurements, which contribute to the clinical respiratory score, were not obtained at the first time point due to practical limitations. 4 blood samples, a total of 260 samples, were collected across the 4 time points where blood sampling occurred, remembering that no blood samples were collected at time point 3. It should be noted that not all blood samples could be analyzed for all variables due to insufficient sample volume in some cases. The variable most affected by this issue was total immunoglobulin concentration, for which 18 out of 260 samples could not be analyzed. Before proceeding to the results, it is necessary to briefly describe the statistical methods employed to analyze the data. For certain analyses, extreme outliers in the data were removed, specifically values that exceeded the mean plus or minus 3 times the standard deviation. This procedure resulted in the removal of 2 immunoglobulin M values, 2 neutrophil to lymphocyte ratio values, and 4 eosinophil count values from the data set. For analyzing changes in blood variables over time, a mixed model statistical approach was used with time as a fixed effect and calf as a random effect to account for the fact that multiple measurements were taken from the same animals over time. For variables where the residuals from the initial statistical model did not follow a normal distribution, which is an assumption of standard statistical models, the data were analyzed using alternative statistical distributions appropriate for the data structure. Specifically, a log normal distribution was used for most blood variables except red blood cell count, hemoglobin concentration, and lymphocyte count, which could be analyzed using a normal distribution. For comparing blood variables across different levels of thoracic ultrasound scores and clinical respiratory scores, similar mixed model approaches were used with the ultrasound or clinical score as the fixed effect and calf as a random effect. Again, various statistical distributions were employed depending on which distribution best fit the data for each particular blood variable. Finally, to assess the degree of agreement between thoracic ultrasound scoring and clinical respiratory scoring, a weighted kappa statistic was calculated. The kappa statistic is a measure of inter-rater agreement that adjusts for the possibility of agreement occurring by chance alone. Values of kappa can range from -1 to +1, with 0 indicating no agreement beyond what would be expected by chance, and 1 indicating perfect agreement. The weighted version of kappa takes into account the fact that disagreements of different magnitudes should perhaps be weighted differently. For example, a disagreement between a score of 0 and a score of 1 is less severe than a disagreement between a score of 0 and a score of 3. We shall now turn to the results of the study, beginning with descriptive statistics for the thoracic ultrasound scores. As previously mentioned, a total of 325 ultrasound scores were recorded. The distribution of scores varied substantially across the 5 time points. At time point 1, which was pre-transport, 46.9% of calves had an ultrasound score of 0, indicating healthy lungs, while 29.2% had a score of 1, 19.2% had a score of 2, and 4.7% had a score of 3 or greater, indicating severe lung pathology. It is notable that even before transport, more than half of the calves already showed some evidence of lung lesions on ultrasound examination, and nearly 1 in 20 showed severe lesions. This is particularly significant because these animals had all been deemed fit for transport by the exporters and veterinarians involved in the commercial transport operation based on their standard pre-transport health assessments. At time point 2, which was on arrival at the veal farm following transport, the distribution had shifted toward more severe scores. The proportion of calves with healthy lungs, that is ultrasound score of 0, had decreased to 38.1%, while 20.6% had a score of 1, 36.5% had a score of 2, and 4.8% had a score of 3 or greater. Thus, there was a notable increase in the proportion of calves with moderate lung lesions, from 19.2% pre-transport to 36.5% post-transport. At time point 3, which was between 3 and 7 days post-arrival, the prevalence of lung pathology reached its peak. Only 27.7% of calves had healthy lungs according to ultrasound examination, while 23.1% had mild lesions, 38.5% had moderate lesions, and 10.8% had severe lesions. This represents the highest point of respiratory disease burden during the study period, with nearly 3/4 of calves showing evidence of lung pathology and more than 1 in 10 showing severe pathology. By time point 4, at 9 or 10 days post-arrival, there were early signs of recovery. The proportion of healthy calves had increased to 35.9%, while 21.9% had mild lesions, 32.8% had moderate lesions, and 9.4% had severe lesions. Finally, at time point 5, 18 days post-arrival, further recovery was evident, with 41.5% of calves now classified as healthy, 26.2% with mild lesions, 30.8% with moderate lesions, and only 1.5% with severe lesions. Examining the pattern of change in individual animals between time points provides additional insight into the dynamic nature of lung pathology in these transported calves. Between time point 1 and time point 2, that is from pre-transport to arrival, 32.3% of calves had a higher ultrasound score at the later time point, indicating worsening lung pathology, 49.2% had an unchanged score, and 18.5% had a lower score, indicating improvement. Between time point 2 and time point 3, 41.5% showed worsening, 35.4% were unchanged, and 23.1% showed improvement. Between time point 3 and time point 4, the pattern shifted, with only 21.9% showing further worsening, 39.1% remaining unchanged, and 39.1% showing improvement. Finally, between time point 4 and time point 5, the recovery pattern became even more pronounced, with only 18.8% worsening, 29.7% unchanged, and 51.6% showing improvement. It is worth noting that only 4 calves maintained a completely healthy ultrasound score of 0 throughout all 5 time points, indicating that the vast majority of animals in the study experienced at least some degree of lung pathology at some point during the observation period. On the other end of the spectrum, a score of 4 was observed in only 4 instances across all calves and time points, and no instances of score 5 were recorded. Regarding the location of severe lung lesions, 61% of the severe ultrasound scores, meaning scores of 3 or 4, were based on consolidation found solely in the cranial aspect of the right lung, which is the front portion of the right lung. This observation has practical implications that we shall return to later in discussing potential simplified ultrasound screening protocols. Turning now to the clinical respiratory scores, a total of 322 scores were recorded across the 5 time points. The distribution of these scores also varied across time points, but with a somewhat different pattern compared to the ultrasound scores. At time point 1, pre-transport, the clinical scores were generally very low. Specifically, 86.2% of calves had a clinical respiratory score of 0, indicating no clinical signs of respiratory disease. 10.8% had a score of 1, indicating mild signs, and 3.1% had a score of 2, indicating moderate signs. No calves had a score of 3, indicating severe clinical signs at this time point. It should be recalled that the clinical score at this time point did not include rectal temperature due to practical constraints, which may have resulted in some underestimation of respiratory disease at this time point. At time point 2, on arrival at the veal farm, there was a dramatic shift in the clinical score distribution. Only 30.2% of calves now had a score of 0, while 33.3% had a score of 1, 31.7% had a score of 2, and 4.8% had a score of 3. This represents a substantial increase in clinical signs of respiratory disease immediately following transport. At time point 3, between 3 and 7 days post-arrival, 36.9% of calves had a score of 0, 26.2% had a score of 1, 33.8% had a score of 2, and 3.1% had a score of 3. At time point 4, 9, or 10 days post-arrival, 46.2% had a score of 0, 29.2% a score of 1, 21.5% a score of 2, and 3.1% a score of 3. Finally, at time point 5, 18 days post-arrival, 50.8% had a score of 0, 35.9% a score of 1, 10.9% a score of 2, and 3.1% a score of 3. Thus, the clinical scores showed a pattern of rapid increase immediately following transport, followed by gradual recovery over the subsequent weeks. Looking at the individual components that contribute to the total clinical respiratory score provides some additional insight. Across all observations at all time points, elevated rectal temperature contributed an average of 41% to the total clinical score, making it the largest single contributor. Eye discharge contributed an average of 32%, nasal discharge contributed 12%, ear position contributed 10%, and cough contributed only 5% to the total scores. However, it is important to note that an elevated rectal temperature score of 3, indicating a temperature above 40 degrees Celsius, was observed in only 13 instances out of the total 322 observations. Examining individual patterns of change in clinical scores between time points, between time point 1 and time point 2, 58.5% of calves had higher clinical scores at the later time point, 38.5% had unchanged scores, and 3.1% had lower scores. Between time point 2 and time point 3, 26.2% had higher scores, 41.5% were unchanged, and 32.3% had lower scores. Between time point 3 and time point 4, 18.5% had higher scores, 40% were unchanged, and 41.5% had lower scores. Between time point 4 and time point 5, 18.8% had higher scores, 45.3% were unchanged, and 35.9% had lower scores. Unlike the ultrasound scores, where 4 calves maintained a score of 0 throughout the study, no calves maintained a clinical respiratory score of 0 at all time points, indicating that all animals showed at least some clinical signs of respiratory disease at some point during the observation period. However, it should be kept in mind that the clinical score at time point 1 did not include rectal temperature, which might have resulted in some calves being scored as 0 at that time point who would have had a non-zero score if temperature had been included. We now turn to the blood variable results. As previously mentioned, blood samples were collected at 4 time points, specifically time points 1, 2, 4, and 5, but not at time point 3 due to logistical constraints. For the statistical analysis of changes in blood variables over time, 14 different blood variables were examined. These included hemoglobin concentration, red blood cell count, white blood cell count, neutrophil count, lymphocyte count, monocyte count, basophil count, eosinophil count, neutrophil to lymphocyte ratio, serum amyloid A concentration, total immunoglobulin concentration, immunoglobulin A concentration, immunoglobulin G concentration, and immunoglobulin M concentration. Of these 14 variables, 12 showed statistically significant changes over time. Hemoglobin concentration was significantly lower at time point 2 compared to time point 1, decreasing from an estimated mean of 5.30 millimoles per liter at time point 1 to 4.28 millimoles per liter at time point 2, and then remaining at similar levels at time points 4 and 5 with values of 4.76 and 4.86 millimoles per liter respectively. Red blood cell count showed a somewhat different pattern, being lowest at time point 2 with a mean of 6.63 times 10 to the 12th power cells per liter, compared to 6.94 at time point 1, then increasing to its highest value of 7.41 at time point 4, before declining slightly to 7.24 at time point 5. White blood cell count showed a pattern of gradual decline over the study period. At time point 1, the mean was 9.52 times 10 to the 9th power cells per liter. This declined to 8.80 at time point 2, 8.54 at time point 4, and 8.27 at time point 5. Neutrophil count showed a sharp decrease between time point 1 and time point 2, from 4.21 times 10 to the 9th power cells per liter to 3.43, followed by a gradual increase to 3.86 at time point 4 and 3.95 at time point 5. The neutrophil to lymphocyte ratio, which is calculated by dividing the neutrophil count by the lymphocyte count, showed a pattern of remaining relatively stable at time points 1, 2, and 4, with values of 0.96, 0.93, and 0.93 respectively, before declining significantly to 0.81 at time point 5. Lymphocyte count decreased substantially between time point 1 and time point 2, from a mean of 4.57 times 10 to the 9th power cells per liter to 3.88, and then remained at similar levels of 4.17 at time point 4 and 3.99 at time point 5. Monocyte count showed a pattern of gradual decline, from 0.61 times 10 to the 9th power cells per liter at time point 1, to 0.51 at time point 2, 0.47 at time point 4, and 0.41 at time point 5. Basophil count was low at time point 1 with a mean of 0.016 times 10 to the 9th power cells per liter, increased to 0.025 at time point 2, reached its peak of 0.031 at time point 4, and declined to 0.021 at time point 5. Eosinophil count showed a dramatic decrease between time point 1 and time point 2, from 0.15 times 10 to the 9th power cells per liter to 0.044, remained low at 0.054 at time point 4, and then increased somewhat to 0.082 at time point 5. Serum amyloid A concentration, the acute phase protein that increases during inflammation, showed a pattern of gradual decline from time point 1 through time point 5. The values were 65.4 mg per liter at time point 1, 54.1 at time point 2, 46.4 at time point 4, and 38.0 at time point 5. Total immunoglobulin concentration was 15.9 grams per liter at time point 1, declined to 12.7 at time point 2, remained at 13.6 at time point 4, and increased to 15.5 at time point 5. Immunoglobulin A showed no significant changes over time, with values ranging from 0.23 to 0.30 grams per liter at the different time points. Immunoglobulin G concentration was 15.2 grams per liter at time point 1, decreased to 12.2 at time point 2, increased slightly to 13.1 at time point 4, and further increased to 14.8 at time point 5. Immunoglobulin M concentration was relatively stable across time points, with values of 444, 423, 474, and 537 mg per liter at time points 1 through 5 respectively. Having described the individual patterns of change for the three diagnostic methods over time, we now turn to the comparative analyses examining relationships between these methods. First, we shall examine the relationship between thoracic ultrasound scores and blood variables. For this analysis, blood variables were compared across the 4 ultrasound score categories: 0, 1, 2, and 3 or greater. Of the 14 blood variables examined, 5 showed statistically significant relationships with ultrasound score. Lymphocyte count was significantly lower for ultrasound scores of 3 or greater compared to scores of 1 or 2. Specifically, the mean lymphocyte count was 3.48 times 10 to the 9th power cells per liter for ultrasound score 3 or greater, compared to 4.43 for score 1 and 4.36 for score 2. The lymphocyte count for score 0, at 4.09, was intermediate and not significantly different from any of the other categories. This pattern of reduced lymphocyte count in association with more severe ultrasound findings is consistent with the lymphopenia that has been documented in previous studies of calves with respiratory disease. Serum amyloid A concentration showed the opposite pattern, being significantly higher for ultrasound scores of 2 and 3 or greater compared to score 0. The mean serum amyloid A was 42.1 mg per liter for score 0, compared to 65.4 for score 2 and 73.3 for score 3 or greater. The value for score 1, at 49.5, was intermediate. This elevation of serum amyloid A in association with lung pathology detected by ultrasound is consistent with the acute phase response to inflammation or infection. Total immunoglobulin concentration was significantly lower for ultrasound score 3 or greater compared to score 2. The mean total immunoglobulin was 10.7 grams per liter for score 3 or greater, compared to 16.0 for score 2. The values for scores 0 and 1, at 14.0 and 14.6 respectively, were intermediate. Similarly, immunoglobulin G concentration was significantly lower for ultrasound score 3 or greater compared to score 2, with values of 10.0 versus 15.2 grams per liter. This pattern suggests that calves with the most severe lung pathology may have had lower immunoglobulin levels, potentially predisposing them to more severe disease, or alternatively that severe disease led to consumption or degradation of immunoglobulins. Immunoglobulin M concentration showed yet another pattern, being significantly lower for ultrasound score 0 compared to scores 1 or 2. The mean immunoglobulin M was 423 mg per liter for score 0, compared to 508 for score 1 and 524 for score 2. The value for score 3 or greater, at 461, was intermediate. This elevation of immunoglobulin M in calves with mild to moderate lung lesions could represent an antibody response to respiratory pathogens. The other 9 blood variables examined, specifically hemoglobin, red blood cell count, white blood cell count, neutrophil count, neutrophil to lymphocyte ratio, monocyte count, basophil count, eosinophil count, and immunoglobulin A, did not show statistically significant relationships with thoracic ultrasound score in this analysis. Next, we examined the relationship between clinical respiratory scores and blood variables. For this analysis, blood variables were compared across the 4 clinical score categories: 0, 1, 2, and 3. Of the 14 blood variables examined, 4 showed statistically significant relationships with clinical score, although one of these was only marginally significant. Hemoglobin concentration was significantly lower for clinical scores of 1 and 2 compared to score 0. The mean hemoglobin was 5.30 millimoles per liter for score 0, compared to 4.57 for score 1 and 4.36 for score 2. The value for score 3, at 4.85, was intermediate but not significantly different from other groups. This reduction in hemoglobin associated with clinical signs of respiratory disease could reflect various physiological processes, including reduced feed intake leading to iron deficiency, or dilution effects from inflammation-related fluid shifts. White blood cell count showed a similar pattern, being significantly lower for clinical scores of 1 and 2 compared to score 0. The mean white blood cell count was 9.52 times 10 to the 9th power cells per liter for score 0, compared to 8.71 for score 1 and 8.24 for score 2. The value for score 3, at 8.64, was intermediate. This somewhat paradoxical finding of lower white blood cell counts in animals with more clinical signs of disease could reflect stress-induced redistribution of white blood cells from circulation into tissues, or it could reflect the timing of sampling relative to the infection course. Lymphocyte count was also significantly lower for clinical scores of 1 and 2 compared to score 0. The mean lymphocyte count was 4.57 times 10 to the 9th power cells per liter for score 0, compared to 4.07 for score 1 and 3.85 for score 2. The value for score 3, at 4.30, was intermediate. This lymphopenia in clinically affected animals is consistent with the pattern seen in relation to ultrasound scores and with previous studies of respiratory disease. Eosinophil count showed a statistically significant overall effect of clinical score, but none of the pairwise comparisons between individual score categories reached statistical significance, making the interpretation of this finding unclear. Red blood cell count showed a marginal overall effect with a p-value of 0.0504, just above the conventional significance threshold of 0.05, and similarly showed no significant differences in pairwise comparisons. The remaining 9 blood variables, including neutrophil count, monocyte count, basophil count, neutrophil to lymphocyte ratio, serum amyloid A, total immunoglobulins, and immunoglobulins A, G, and M, did not show statistically significant relationships with clinical respiratory score. Finally, we turn to the direct comparison between thoracic ultrasound scores and clinical respiratory scores, examining the degree to which these two methods agreed in their classification of individual animals. A weighted kappa statistic was calculated to assess this agreement, yielding a value of 0.038 with a 95% confidence interval ranging from -0.034 to +0.110. This kappa value very close to zero indicates essentially no agreement between the two scoring methods beyond what would be expected by chance alone. The confidence interval, which includes both negative and positive values, underscores the uncertainty in even this very low level of agreement. Examining the cross-tabulation of ultrasound and clinical scores in more detail reveals the nature of this disagreement. At time point 1, pre-transport, 86.2% of calves had a clinical score of 0, suggesting they were clinically healthy. However, among these clinically healthy animals, 30% had an ultrasound score of 2 or 3, indicating moderate to severe lung pathology. Conversely, among the 46.9% of calves with an ultrasound score of 0 at this time point, only 10% had a clinical score of 1, and none had higher clinical scores. This pattern suggests that ultrasound was detecting substantial lung pathology in animals that appeared clinically normal based on the clinical scoring system. Perhaps most strikingly, across all observations at all time points, there was never an instance where a severe ultrasound score, meaning score 3 or greater, coincided with a severe clinical score of 3. This complete lack of overlap at the severe end of both scales further illustrates the fundamental disconnect between these two diagnostic approaches. In summary, the results of this study revealed several important findings. First, the prevalence of lung pathology detected by thoracic ultrasound was high both before and after transport, with only 47% of calves having healthy lungs pre-transport and this proportion declining to as low as 28% at 1 week post-transport before partially recovering to 42% by 3 weeks post-transport. Second, clinical respiratory scores showed a different temporal pattern, with a rapid increase immediately following transport followed by gradual recovery, but overall indicating less respiratory disease than was detected by ultrasound. Third, there was essentially no agreement between ultrasound and clinical scoring in classifying individual animals. Fourth, several blood variables showed relationships with ultrasound scores, particularly lymphocyte count, serum amyloid A, and immunoglobulins, while fewer blood variables showed relationships with clinical scores. Fifth, the patterns of change in individual animals over time were highly variable, with many animals showing fluctuating scores rather than consistent progression or recovery. The authors of the study discussed several implications of these findings. Regarding the discordance between ultrasound and clinical scoring, they noted that this confirms previous research showing that clinical scoring has poor sensitivity for detecting respiratory disease. The ability of ultrasound to detect lung pathology in clinically normal animals likely reflects the fact that ultrasound can identify subclinical disease before clinical signs become apparent. However, the authors also noted that when severe lung consolidation is present, clinical signs would typically be expected to appear, so the fact that severe ultrasound findings did not consistently correspond to severe clinical scores is somewhat puzzling and may warrant further investigation. To elaborate more extensively on the implications of the poor agreement between ultrasound and clinical scoring, we must consider what this discordance means for current practice in the livestock transport industry. The current regulatory framework governing fitness for transport relies heavily on visual assessment of clinical signs, with veterinarians or trained animal health technicians conducting pre-transport inspections to identify animals that are unfit for transport due to disease, injury, or other conditions that would make transport likely to cause unnecessary suffering. The criteria used in these assessments typically include general appearance and behavior, presence of discharge from eyes or nose, respiratory signs such as coughing or labored breathing, temperature elevation, and other visible indicators of disease. These criteria are essentially the same parameters that comprise clinical respiratory scoring systems, such as the Wisconsin scoring system used in the current study. The finding that clinical scoring identified only a small fraction of the animals that had lung pathology detectable by ultrasound suggests that the current pre-transport inspection protocols are inadequate for identifying animals with respiratory disease, particularly subclinical disease. The implications of this inadequacy extend in multiple directions. From an animal welfare perspective, the transport of animals with existing respiratory pathology, even if subclinical, raises concerns because the stresses of transport may cause that subclinical disease to progress to clinical disease, with attendant suffering for the affected animals. The fact that lung pathology worsened in many calves between pre-transport assessment and arrival at the destination, and worsened further in the first week after arrival, suggests that transport is indeed acting as a trigger for disease progression in animals with pre-existing lesions. If these animals with pre-existing lesions could be identified and held back from transport until recovered, this progression might be prevented. From a disease control perspective, animals with existing respiratory infections serve as sources of pathogens that can be transmitted to other animals during commingling and transport, increasing the overall disease burden in the transported population. Removing infected animals from transport groups would reduce this pathogen transmission and might lower the incidence of new infections developing during and after transport. From an economic perspective, animals that develop severe respiratory disease post-transport require treatment, may experience reduced growth, and may die, all of which represent economic losses. If pre-transport screening could identify high-risk animals, these losses might be reduced through targeted interventions such as treatment before transport or diversion to different marketing channels that do not involve transport. However, implementing ultrasound screening as a routine pre-transport assessment faces substantial practical challenges. The time required for thoracic ultrasound examination represents a major constraint. In the current study, where a comprehensive ultrasound examination of all intercostal spaces on both sides was performed, each examination required approximately 4 minutes per calf according to published literature on this ultrasound protocol. For a transport load of, for example, 100 calves, this would represent nearly 7 hours of examination time for a single operator, not accounting for time required for animal handling, preparation of the scanning area, cleaning of equipment between animals, and documentation of findings. This time requirement is impractical in commercial settings where large numbers of animals must be assessed in limited time frames to meet transport departure schedules. The suggestion by the authors that simplified ultrasound protocols examining only selected lung regions might reduce examination time is relevant to addressing this constraint, but requires validation to ensure that sensitivity for detecting disease is not unacceptably compromised. The observation in the current study that 61% of severe lesions were located in the right cranial lung area provides some support for the feasibility of focus scanning protocols, though this also means that 39% of severe lesions would potentially be missed if only that region was scanned. Cost represents another significant practical barrier to routine ultrasound screening. Ultrasound equipment suitable for thoracic examination represents a substantial capital investment, ranging from several thousand to tens of thousands of currency units depending on the sophistication of the equipment. This equipment must be purchased and maintained, and operators must be trained in proper ultrasound technique and image interpretation. The costs of this equipment, training, and the time required for examinations must ultimately be borne by someone in the production chain, whether that be the farmer selling calves, the transport company, the purchaser receiving calves, or some combination of these parties. The economic viability of ultrasound screening would depend on whether the benefits in terms of reduced disease, improved welfare, and potentially improved regulatory compliance outweigh these costs. This cost-benefit calculation would likely vary depending on the specific context, including factors such as the baseline prevalence of respiratory disease in the population, the value of the animals being transported, the distance and duration of transport, and regulatory requirements. The authors suggested that the discordance between the two methods has important practical implications for fitness for transport assessments. Relying solely on clinical scoring, which is the current standard practice, appears to result in substantial under-identification of animals with lung pathology. The observation that nearly 1/4 of calves deemed fit for transport based on standard procedures had moderate to severe lung lesions on ultrasound examination raises questions about whether transport fitness criteria should be revised to incorporate ultrasound screening, despite the practical challenges this would entail. Regarding the blood variables, the authors noted that the more consistent relationships between blood parameters and ultrasound scores compared to clinical scores provides further evidence that ultrasound is detecting genuine pathology that is having measurable physiological effects on the animals. The lymphopenia associated with both severe ultrasound findings and clinical disease is particularly notable as it is a well-documented response to respiratory infection in calves. The elevation in serum amyloid A in association with ultrasound-detected lung pathology confirms that animals with consolidation visible on ultrasound are experiencing an inflammatory response, even if they do not yet show overt clinical signs. To expand on the interpretation of blood variable findings, it is important to consider what each significant finding tells us about the pathophysiology of respiratory disease in transported calves. The lymphopenia, or reduced lymphocyte count, observed in association with severe ultrasound findings represents a complex phenomenon that may reflect multiple underlying processes. Lymphocytes are critical components of the adaptive immune system, with different lymphocyte subsets playing different roles. B lymphocytes are responsible for antibody production, while T lymphocytes include helper cells that coordinate immune responses, cytotoxic cells that kill infected cells, and regulatory cells that modulate immune activity. During acute infection and inflammation, lymphocyte counts in peripheral blood can decline for several reasons. First, lymphocytes may be recruited from circulation into tissues, particularly into the sites of infection and associated lymph nodes, where they participate in local immune responses. This redistribution results in reduced numbers in circulation even though the total body lymphocyte pool may not be reduced. Second, stress hormones, particularly cortisol, have lympholytic effects, meaning they can cause destruction of lymphocytes and also cause redistribution of lymphocytes from blood into lymphoid tissues. Given that transported calves experience substantial stress, as evidenced by elevated cortisol levels documented in previous transport studies, this stress-mediated lymphopenia likely contributes to the reduced lymphocyte counts observed. Third, severe inflammation can lead to consumption of lymphocytes at infection sites and may trigger apoptosis, which is programmed cell death in lymphocyte populations. The fact that lymphopenia was associated with severe ultrasound findings but not with mild ultrasound findings suggests that more extensive lung pathology creates a greater demand for lymphocyte participation in local immune responses or a greater degree of systemic stress response. The elevation of serum amyloid A in association with ultrasound-detected lung lesions provides clear evidence of an acute phase response, which is a systemic reaction to inflammation, infection, or tissue injury. The acute phase response involves changes in the synthesis of various plasma proteins by the liver, with some proteins increasing, termed positive acute phase proteins, while others decrease, termed negative acute phase proteins. Serum amyloid A is one of the major positive acute phase proteins in cattle, along with haptoglobin. The production of these proteins is stimulated by pro-inflammatory cytokines, particularly interleukin-6, interleukin-1, and tumor necrosis factor alpha, which are released at sites of inflammation and travel through the bloodstream to the liver, where they trigger changes in hepatic protein synthesis. The magnitude of the acute phase response generally correlates with the severity of the inflammatory stimulus, which is consistent with the finding in the current study that serum amyloid A was elevated in calves with moderate to severe ultrasound findings, but not in those with healthy lungs or mild lesions. The acute phase proteins serve various functions thought to be beneficial in host defense and tissue repair, though some aspects of the acute phase response may also contribute to disease pathology. Serum amyloid A, specifically, has been shown to have antimicrobial properties, to modulate immune cell function, and to participate in lipid metabolism during inflammation. Clinically, measurement of acute phase proteins like serum amyloid A has been proposed as a diagnostic tool for detecting disease in cattle, with the advantage of being a more objective measurement than visual assessment of clinical signs. However, acute phase proteins are not specific to respiratory disease and will increase in response to any significant inflammatory stimulus, including mastitis, metritis, lameness, or other conditions, which limits their specificity as diagnostic markers. The changes in immunoglobulin levels in relation to ultrasound findings are more complex to interpret. The lower immunoglobulin levels in calves with the most severe lung pathology could indicate that these animals had poorer passive transfer of maternal antibodies and were thus more susceptible to severe disease. Alternatively, severe disease may lead to immunoglobulin consumption or loss. The elevation in immunoglobulin M in calves with mild to moderate ultrasound findings could represent an active antibody response to respiratory pathogens. However, the authors noted that definitive interpretation of immunoglobulin patterns would require additional information about maternal antibody transfer and pathogen-specific antibody responses. To further elaborate on immunoglobulin interpretation, we must consider the sources and dynamics of immunoglobulins in young calves. Calves are born with very low levels of immunoglobulins because bovine placental structure does not permit significant transplacental transfer of antibodies from mother to fetus during gestation. Consequently, newborn calves must acquire passive immunity through consumption of colostrum, which is the first milk produced after calving and which contains very high concentrations of immunoglobulins, particularly immunoglobulin G. The adequacy of passive transfer depends on multiple factors, including the immunoglobulin concentration in the colostrum, the volume of colostrum consumed, the timing of consumption relative to birth, and the efficiency of intestinal absorption, which declines rapidly in the hours after birth as the intestinal epithelium matures and loses its capacity to absorb large proteins intact. Calves with inadequate passive transfer, meaning low serum immunoglobulin concentrations, are at substantially increased risk for infectious disease because they lack the protective antibodies needed to prevent or limit infections. In the current study, total immunoglobulin levels and specifically immunoglobulin G levels were lower in calves with severe ultrasound findings compared to those with moderate findings. This pattern could be interpreted as suggesting that calves with poorer passive transfer were indeed more susceptible to developing severe respiratory disease. However, an alternative interpretation is that the severe disease process itself led to consumption or catabolism of immunoglobulins, or potentially to loss of immunoglobulins through damaged respiratory epithelium into the airways and subsequent clearance in respiratory secretions. Distinguishing between these interpretations would require knowledge of immunoglobulin levels before disease developed, which was not available in the current study as the first sampling occurred at the pre-transport time point when some calves already had lung lesions. The elevation in immunoglobulin M associated with mild to moderate ultrasound findings presents a different interpretive challenge. Immunoglobulin M is typically the first antibody class produced in response to a new antigenic stimulus, with IgM responses generally occurring earlier in the course of infection than IgG responses. An elevation in IgM could therefore represent an active antibody response to respiratory pathogens. However, in the context of young calves that have acquired maternal immunoglobulins through colostrum, the IgM measured in serum could include both maternally derived IgM that was absorbed from colostrum and calf-produced IgM synthesized in response to antigenic stimulation. Maternally derived antibodies gradually decline over the first weeks to months of life as they are catabolized, while calf-produced antibodies begin to accumulate as the calf's own immune system matures and responds to environmental antigens. The relative contributions of maternal and calf-produced immunoglobulins to the total IgM measured at any given time point would depend on the age of the calf, the amount of IgM in the colostrum consumed, and the antigenic stimulation the calf has experienced. Pathogen-specific antibody measurements, meaning measurements of antibodies directed against specific respiratory pathogens such as bovine respiratory syncytial virus or Mannheimia hemolytica, would provide more definitive information about whether elevated immunoglobulin levels represent active responses to respiratory infections, but such measurements were not performed in the current study. The authors acknowledged several limitations of their study. First, the batch antibiotic treatment administered to all calves as part of standard veal farm practice likely influenced disease progression and may have limited the occurrence of severe clinical disease. This antibiotic treatment is standard practice in commercial veal systems and could not be eliminated without compromising animal welfare, but it does mean that the results may not fully represent the natural progression of untreated respiratory disease. To elaborate further on this limitation, the effects of antibiotic treatment on the study findings must be carefully considered. The calves in this study received 3 separate courses of antibiotics. The first was an intramuscular injection of tilmicocin given to all calves shortly after arrival at the veal farm. Tilmicocin is a macrolide antibiotic with activity against many of the bacterial pathogens commonly involved in bovine respiratory disease, including Mannheimia hemolytica, Pasteurella multocida, and Histophilus somni. This treatment would be expected to reduce bacterial populations in the respiratory tract and to prevent or limit bacterial pneumonia. The second and third courses of antibiotics consisted of oral doxycycline, a tetracycline antibiotic also with broad-spectrum activity against respiratory pathogens, administered in the milk for 3 days during week 1 and for 5 days during week 2 after arrival. These prophylactic or metaphylactic antibiotic treatments, meaning antibiotics given to prevent disease or to treat early disease before clinical signs are apparent, are standard practice in many veal operations because of the high risk of respiratory disease in recently transported and commingled calves. From an animal welfare perspective, this practice can be justified as preventing suffering from respiratory disease. From an antimicrobial stewardship perspective, however, routine metaphylactic use of antibiotics is controversial because it contributes to overall antimicrobial use in livestock production and may promote development of antimicrobial resistance. The relevance to the current study is that these antibiotic treatments likely prevented some cases of respiratory disease from developing and caused some existing infections to resolve more quickly than they would have without treatment. This means that the prevalence and severity of respiratory disease observed in the study may underestimate what would occur in untreated populations. The discordance between ultrasound and clinical findings might have been even more pronounced in the absence of antibiotic treatment, as more animals with ultrasound-detected lesions might have progressed to develop clinical signs if untreated. Additionally, the patterns of change in blood variables over time may have been influenced by antibiotic effects on infection progression. These considerations do not invalidate the study findings, but they do mean that the results are most directly applicable to commercial veal systems where similar antibiotic protocols are used, and may not generalize fully to situations where antibiotics are not administered. Second, the fact that blood samples were not collected at time point 3, when ultrasound and clinical findings were at their peak, likely reduced the ability to detect correlations between blood variables and the other diagnostic methods. Third, the use of different laboratory instruments to analyze blood samples collected in Ireland versus the Netherlands introduced potential variability, although quality control procedures suggested that this was minimized. Fourth, the pooling of ultrasound scores 3 and 4 into a single category due to the rarity of score 4 observations may have reduced the ability to detect relationships at the most severe end of the disease spectrum. Additional limitations not explicitly discussed by the authors but worth considering include the relatively small sample size of 65 calves, which limits statistical power to detect small to moderate effects and to perform more complex multivariable analyses examining interactions between different factors. The study was also limited to 2 cohorts transported at specific times in spring, which means that seasonal effects on respiratory disease could not be examined, and the findings may not generalize to other seasons when weather conditions, pathogen prevalence, or management practices might differ. The study examined only 1 transport route and 1 destination veal farm, which limits generalizability to other routes, other transport operators with potentially different handling and management practices, and other destination facilities with different housing, feeding, and health management protocols. The specific breeds and types of calves included in the study, predominantly dairy breed male calves and beef cross calves, mean that findings may not generalize to other calf types such as purebred beef calves or dairy breed female calves. Finally, the study did not include pathogen identification through bacterial culture, viral isolation, or molecular testing such as polymerase chain reaction, which means that the specific infectious agents responsible for the respiratory disease observed could not be determined. Knowledge of the specific pathogens involved would provide valuable information for designing targeted prevention and treatment strategies. The authors concluded that thoracic ultrasonography appears to be a more sensitive method than clinical respiratory scoring for detecting respiratory pathology in transported calves, as evidenced by its ability to detect lung lesions in clinically normal animals and its stronger relationships with blood markers of immune function and inflammation. However, they acknowledged that ultrasound examination requires more time, specialized equipment, and operator training compared to clinical scoring, which creates practical barriers to its routine use in commercial settings. They suggested that simplified ultrasound protocols, such as scanning only the right cranial lung lobe where the majority of severe lesions were located, might reduce the time required and make the technique more feasible for field use. They also suggested that the high prevalence of lung pathology detected both before and after transport indicates a need for broader examination of respiratory disease control strategies in dairy calf rearing and transport systems, not just improvements in diagnostic methods. In terms of future research directions, the authors suggested several areas warranting further investigation. First, studies examining whether pre-transport ultrasound screening can predict which animals are most likely to develop severe respiratory disease post-transport would help determine whether selective exclusion of high-risk animals from transport could reduce overall disease burden. Second, research into simplified ultrasound protocols that maintain acceptable sensitivity while reducing examination time would improve the practical feasibility of ultrasound screening. Third, investigation into the causes of the high baseline prevalence of lung pathology in pre-transport calves could identify opportunities for preventing respiratory disease before animals enter the transport chain. Fourth, studies examining the long-term consequences of early lung pathology on growth performance and subsequent disease susceptibility would help quantify the economic impacts and prioritize prevention strategies. To expand on these future research directions, the predictive value of pre-transport ultrasound screening represents a particularly important question for practical application. If ultrasound findings at the pre-transport time point could reliably predict which animals will develop severe respiratory disease post-transport, this would provide a rational basis for selective exclusion of high-risk animals from transport. Such a predictive model would need to account for not only ultrasound findings but potentially also clinical signs, blood variables, and other risk factors such as age, weight, passive transfer status, and farm of origin. The development and validation of such predictive models would require larger datasets than the current study, ideally including multiple transport cohorts across different seasons and involving different transport routes and destination facilities. The model would need to demonstrate adequate sensitivity and specificity for identifying high-risk animals, and the practical implementation would need to consider the costs of screening versus the benefits of reduced disease. Economic modeling could help determine the threshold level of pre-transport lung pathology at which exclusion from transport becomes economically justified based on expected disease costs and impacts on animal performance. Research into simplified ultrasound protocols is already underway in veterinary medicine more broadly, with various studies examining focused lung ultrasound techniques that examine only specific lung regions rather than comprehensive scanning of all lung fields. These focus techniques have been shown to reduce examination time while maintaining reasonable sensitivity for detecting significant pathology in some contexts. For application to pre-transport screening, validation would be needed to determine which specific lung regions should be examined, how many examination points are needed for adequate sensitivity, and what scoring criteria should be applied. The current studies finding that the right cranial lung region contained the majority of severe lesions provides a starting point for designing focused protocols, but additional research across larger and more diverse populations would be needed to confirm whether this pattern holds consistently. Training and standardization are also important considerations, as the simplified protocols would need to be teachable to personnel in commercial settings who may not have extensive veterinary ultrasound experience, and interoperator reliability would need to be established through formal validation studies. Investigation into the causes of the high baseline prevalence of pre-transport lung pathology represents another critical research priority. The finding that more than half of calves already had ultrasound evidence of lung lesions before transport, and that nearly 25% had moderate to severe lesions, indicates that respiratory disease is already a substantial problem in the dairy calf rearing systems from which these transport calves originated. This raises questions about housing, management, nutrition, colostrum management, and other factors on dairy farms that may predispose to respiratory disease in young calves. Research examining the risk factors for respiratory disease in pre-weaned dairy calves, including both environmental factors such as housing type, ventilation, and stocking density, and management factors such as colostrum feeding practices, milk feeding amounts and schedules, age at weaning, and group size, could identify modifiable factors that might reduce respiratory disease prevalence. Intervention studies testing specific management changes, such as improved colostrum management protocols, enhanced ventilation in calf housing, or different group housing strategies, would be needed to establish causal relationships and to determine which interventions are most effective and cost-effective for reducing respiratory disease. Finally, studies of the long-term consequences of early lung pathology would provide important information about the broader impacts of respiratory disease beyond the immediate morbidity and mortality. Previous research has shown that calves that experience respiratory disease have reduced average daily gain during the period of active disease and may have persistently reduced growth rates even after apparent clinical recovery. The mechanisms underlying these long-term growth impacts may include permanent damage to lung tissue reducing respiratory capacity and oxygen exchange, metabolic costs of tissue repair and immune responses diverting nutrients away from growth, and behavioral changes such as reduced feed intake that persist after disease resolution. Longer-term follow-up studies tracking calves from transport through finishing or through the productive lifespan for dairy replacements could quantify the magnitude of these effects on economically important outcomes such as days to slaughter weight, feed efficiency, carcass quality, age at first calving, and milk production. Such information would help establish the full economic burden of respiratory disease and would strengthen the economic case for preventive interventions. This concludes our examination of this research study on respiratory dysfunction in transported calves. Thank you for your attention, or alternatively, your restful repose, during this session of the Boring Lecture Series. We hope this has been a useful resource for your studies or a supportive environment for your rest. This lecture was narrated by Dr. Owen On, an artificial voice for the Boring Lecture Series. Please see the description for further resources and the complete citation to the primary literature discussed throughout this presentation. If you found this level of detail sufficient, please consider subscribing for our weekly sessions. We will now fade to soothing bioacoustic sounds and ambient tones to allow for a period of quiet reflection or continued rest. Good night.